Today we have a 59-year-old male. His height is 170 centimeters, weight is 80 kilograms, and his BMI is 27.68, which is considered overweight. The patient's being referred to us today because he recently had a small bowel obstruction and he needed a nutrition referral. So currently we don't have any nutrition-related history available to us. We do not have any specific labs available, but we do have a few laboratory-based diagnoses from his medical history. His small bowel obstruction has been somewhat alleviated by a laparotomy with lysis of the adhesions. His stomach is being decompressed with an NG tube, but currently he still has some abdominal distension present. Upon admission, he had vomiting and abdominal distension, hyperactive bowel sounds, which are common. It's your body basically trying to loosen that obstruction on its own. He has some hypovolemia, which is simply abnormally low blood plasma volume, and that in turn cause hemoconcentration, which is an increased density of those foreign minerals present in the blood, and from that he also has the electrolyte imbalances. The hypervolemia, in combination with the abdominal distension, just wanted to explain that briefly. What happens is your stomach and intestines are responsible for reabsorbing a lot of the water, and when they're not functioning correctly, the water is just maintaining itself within the abdomen instead of being reabsorbed into the blood systems, which is why you're seeing a lower plasma concentration, and then you're seeing all of the items within the blood being concentrated and to abnormal levels. So 5 years ago, he had an umbilical hernia reduction, which is important for his current diagnosis because it's potentially a trigger point for him. So looking at basically what the umbilical hernia is, it's around the belly button. The tissue was weakened or stressed in some way, and there was pressure put on the intestines in this case, in this picture, and the pressure pushed through that weakened part of the abdominal wall to form this small sac where, the organs and the fluids are all pushing past the normal peritoneum. To repair that, what doctors would do is hopefully laparoscopically go in. This is almost the camera angle you would get looking at it laparoscopically. Make a few small incisions and pull back the organs that are protruding through the abdominal wall and place almost just a patch. This is called a mesh over that weakened area of the abdomen to prevent the intestines from pushing through that weakened area again. So that is important because any sort of abdomen surgery anything that's exposing your internal organs can lead to those abdominal adhesions, which is part of the reason why the patient developed a small bowel obstruction. And those adhesions are simply bands of tissue that form between the abdominal tissue and the organs, causing the organs to stick together rather than being able to move smoothly as they're pushing food through the GI tract. And then they even get caught and get that obstruction caught up inside as well. So moving on, the patient's current skin status, as far as we know, is intact. He does have a few surgical wounds from the laparotomy. We used his actual body weight to determine his needs, as that's the standard for the evidence analysis library and nutrition care manual. So using Harris Benedict and an activity factor of 1.4, because as far as we know right now, he's pretty sedentary. He's on bowel rest. I'm sure he's not up running around. We got a caloric need of 2,200 calories per day. His protein needs, I did 1 to 1.2, which is pretty common for surgical patients. And that gives us 80 to 96 grams of protein per day. And his fluid is the normal 25 to 30 milliliters per kilogram, which is 2 to 2.4 liters per day. The patient's current diet order is NPO, as he is on bowel rest. At this point in time, we're not sure of his feeding abilities, oral problems, or intake. We don't have any information indicating if he does have problems or even what his past intake was. So at this point, we can't fill out that part of the form. So moving on to his diagnosis, he's been diagnosed with altered GI function related to small bowel obstruction and abdominal adhesions, as evidenced by his abdominal distension, 15 milliliter NG output, and NPO status and bowel rest. Moving down to the intervention, once the patient's able to progress towards solid foods again, we would recommend a low residue, low fiber diet, and that's actually a recommendation from the International Foundation for Functional GI Disorders. And the low fiber is considered 10 to 15 grams or less than 10 grams per day. And the low residue is kind of defined as anything that is smaller particles, so milk-based proteins, small digestible particles to prevent things from reblocking up the small intestine. Once the patient is eating again, we'd want to just educate them on low residue diets, as they will most likely be following it for at least a while after they're discharged. We'd want to coordinate care with the GI doctor just to determine when we're able to feed the patient again. At this point, he's got quite a bit of NG output still, about 1,500 milliliters. So that's quite a bit. We'd have to wait until that was reduced. So our goals are going to be to advance his diet within 4 to 6 days. Any more time after that, we'd want to consider some sort of peripheral support, but we can't predict that at this point. So we want to advance his diet to more solid foods within 4 to 6 days. We also want to see GI tolerance of the diet when he is advanced, and these are just the indicators for that. So we want, positive bowel sounds, not the hyperactive ones, just in the one spot before the obstruction, but we want to hear bowel sounds throughout the bowels and the abdomen. We want to see bowel movements, reduced bowel distension, and the NG tube needs to be removed before we can feed the patient as well. As far as tolerance, we want to make sure the patient's not having nausea, vomiting, constipation, or diarrhea while he's eating, not having any sort of abdominal pain, and we want to see that he is having bowel movements. That's always a good thing, and that means that things are moving along and not still getting blocked up in his intestines. So just as another side note with this patient as well, just because I've had a little bit of experience with small bowel obstruction patients being readmitted, one thing that we'd want to look at and possibly track if this is a common problem in a facility is whether the patient was trialed on solid foods before he was discharged or not. And then if they are readmitted within 30 days, or even within 60 days, like were they trialed on the solid foods, did they tolerate it before they were discharged, and then were they readmitted after that, because we do not want to see any sort of readmission rate. And statistically speaking, if patients do not tolerate solid foods and cannot sustain themselves prior to being discharged from the hospital, it's more likely that they will be readmitted within the 30-day to 60-day span. And these are just my references and assumptions. Thank you.